I am delighted to welcome you to today's webinar, which concerns atrial fibrillation, a common and serious disorder of heart rhythm which affects people throughout the world. This is one of a series of Healthy Life webinars organised by Healthy Heart charity, the Cardiovascular Research Trust, aiming to provide informative updates for health professionals, members of the public and patients on important, serious, preventable diseases of the heart, brain and circulation. Today we have an excellent panel. We shall hear from a patient. We shall hear about new ideas for cause and treatment of the condition and what we should be doing in terms of best current practice. We're going to start by hearing about a patient's experience of the condition. I'm delighted that our trustee, John Jackson, has agreed to tell us what happened.
This is just a summary of my life before atrial fibrillation, and you see the activities that I was interested in and capable of doing. And in general terms, I was a pretty fit guy for somebody in his mid-60s. And my first episode came in the early hours of the morning, a thumping in my back, no apparent cause, and asymptomatic in all other respects. And that's been my experience of AF episodes ever since. They have been of various durations and on occasions over 24 hours. So when that's happening, it's pretty frightening. As you'd expect, referred to a cardiac specialist through the NHS and following an angiogram, a diagnosis of 3 blockages on the left-hand side of my heart. So the principal treatment was a triple bypass in January 2017, left atrial appendage removed, and what was described to me as surgical ablation, which very unfortunately did not resolve all my AF episodes. So I had a supplementary electrical ablation in October of that year, which did solve most of my problems. But also in the course of the procedure revealed stenosis of pulmonary veins on my left side. So the following year, 2018, I had a third delicate procedure to relieve those veins. While all this was going on, I was on a variety of medication regimes. And I have a particularly bad recollection of being on a concoction of bisoprolol and amiodarone, which I found completely draining and unable to walk much more than 50 meters. So the broad outcomes, before I come to my last slide, are that in the main, my atrial fibrillation is under control. Regrettably, I developed mild angina last year. On a good day, I can walk for miles, and being 70 plus now, I'm broadly speaking pretty happy with my life. However, just after compiling this slide deck for today's webinar, I had a further AF episode on Wednesday, 3rd of March, very similar in its pattern to my first episode, in that it started in the early hours of the morning. It proved not responsive to bisoprolol at home, so I ended up being admitted to hospital for an overnight stay. I was treated with metoprolol, which sorted me out and brought me back into sinus rhythm after 20 hours or so. Very sadly, because I don't enjoy it, I'm now back on a low dosage of bisoprolol. So in summary, after 5 years when AF first appeared, the quest continues for a cure, a total cure in my case.
Well, thank you very much indeed, John. You really set the scene very well. And with that in mind, what we're going to do now is hear something about hormonal approaches, something about better mapping of the heart in terms of electrical approaches, and then what should we be doing in practice to prevent some of the risks, including emboli causing stroke, and what about good ways to keep the rate under control. So we're going to start now with Svetlana Reilly, who's Associate Professor of Cardiovascular Science, University of Oxford, who's going to discuss ideas about hormonal approaches to dealing with atrial fibrillation. So over to you, Svetlana.
So thank you very much. It's very honorable to speak today to the patients and all the audience about the novel role of cardiac calcitonin in atrial fibrillation. And I will highlight potential translational value of hormonal therapeutics in atrial fibrillation, which is a new direction in treating AF, and it's under development. So the outline of my talk is shown on this slide. I will begin with a few words about atrial fibrillation, and I will emphasize the meaning of atrial fibrosis as a potentially and largely overlooked target in treating atrial fibrillation. Then I will move on to our recent discovery of cardiac calcitonin, which has been published in November in Nature, as shown here. And I will conclude with one summary slide. So what do we know about atrial fibrillation? Why do we need to study it? Obviously, it's a growing epidemic. It is affecting over 33 million people globally. And strikingly, it causes up to 40% of strokes. And this is a major complication of atrial fibrillation, which we have to be aware of. Sadly, as a treatment of atrial fibrillation, as you've just heard from John, is suboptimal, and there are still ways to improve it. Even cardio ablation, which is the most successful therapeutic option, invasive therapy, is only effective in 60% of cases. And obviously, financial burden of this disease is huge, as shown in the US. This country spends $26 billion per year to treat patients with atrial fibrillation. So obviously, we are looking for a better treatment of this disease. Why is it so difficult to treat atrial fibrillation? Well, because it has a progressive nature. And what I mean by saying that, once it occurred, like a short episode in post-operative or paroxysmal AF, it tends to persist and become permanent eventually. And when it becomes permanent, it's very, very, very difficult to reverse it back. It's pretty much impossible. So why AF becomes permanent, why it's so progressive and it's impossible to stop that vicious cycle? It's because atrial fibrillation causes electrical and structural changes in the myocardium, atrial myocardium, which we normally call remodeling. So what is electrical remodeling? Electrical remodeling is very easily seen on normal ECG, on ECG of patients with atrial fibrillation when we don't notice P wave. And we could see that rhythm is irregular. However, the good news about electrical remodeling, it's fully reversible. However, structural changes, they are not that reversible and they are not that benign as electrical remodeling. And structural changes in the atrial myocardium are hallmarked by fibrosis of the atria and ventricle of the whole heart pretty much. And the danger of fibrosis of the atria and ventricle is that it promotes maintenance of atrial fibrillation. As shown on this picture here, in a normal heart, highlighted by arrows, we only have a moderate amount of fibrosis, up to 5%. However, as AF becomes more progressive, paroxysmal, then chronic, the degree of fibrosis increases up to 35%. So a third of our atria becomes fibrotic. So it tells us something that perhaps we have to target fibrosis, of course, in addition to the electrical remodeling, but fibrosis is probably the key to trying to help patients with atrial fibrillation. So what is more alarmingly is that fibrosis itself is a huge problem. Fibrosis in the heart is clinically irreversible to date. And since 2010, the Food and Drug Agency, or FDA, has approved around 30 drugs for cardiovascular diseases, yet not a single drug has been found or approved for atrial fibrosis or cardiac fibrosis. Therefore, we still have a long way to go and to find that pathways that we could target to cure fibrosis. Why we don't have a drug to cure fibrosis is because we don't quite understand the mechanisms of it. but it's of a great clinical importance if we want to prevent AF incidence, progression, and irreversibility. Recent scientific and clinical observations suggest that hormonal abnormalities may lead to atrial fibrillation, and a lot of diseases associated with hormonal abnormalities eventually lead to atrial fibrillation. I cannot speak about each of these hormones and what happens when they are abnormal, and I will only focus on one of them, calcitonin. For the rest of the abnormalities associated and present in hormonal diseases, I would refer you to a review which we've just published in Cardiovascular Research, which talks a bit more in detail about these conditions. So what is calcitonin? Calcitonin is a hormone of the thyroid gland, as we could see here, which is released into the bloodstream, and it binds to the calcitonin receptor, or CTR. On binding to this receptor, calcitonin inhibits calcium reabsorption by kidneys. It increases deposition of calcium in bones. It inhibits calcium absorption in intestine, and it lowers calcium levels in the blood. So it's a major calcium regulating hormone. A few years ago, there was a paper showing that when the receptor for calcitonin was knocked out or deleted from skeletal muscle, it led to an increased degree of fibrosis, as shown here. So these mice had so much fibrosis that this function of the muscle was altered. So at the same time, we found a few studies suggesting that genetic polymorphism in this receptor, calcitonin receptor, is also linked to an important risk factors for atrial fibrillation, such as height and body mass. Therefore, we decided to test a hypothesis that perhaps calcitonin receptor is important for cardiac fibrosis and for atrial fibrillation, only under one condition: if this receptor is expressed in human heart and in the atria. In order to investigate it, we obtained cardiac samples from patients in our hospital, and we detected in green calcitonin receptor in cardiac atrial fibroblasts, as shown here. These cells are important for producing lots of collagen, which is shown here in green. And collagen is the main component of fibrotic tissue. What happened when we pretreated with cells with calcitonin, we noticed that the amount of collagen dropped twice, suggesting that calcitonin perhaps is very important for controlling profibrotic function of human atrial fibroblasts in vitro in a dish. How about in vivo? So we generated a calcitonin receptor knockout mouse model, which is the mouse which was lacking calcitonin receptor. And we found that atria, or part of this mice, had a lot more collagen, shown here in blue, compared to the control mice. And this is telling us that these mice have more fibrosis in the heart, and this is why they are not doing well. So what we did next, we checked whether these mice actually have a higher probability to develop AF or not. And indeed, when we stimulated these mice with electrical stimulation, we found that with calcitonin receptor knockout mice, they developed longer episodes of atrial fibrillation compared to the control mice. And also a high percentage, shown here in black, of mice were prone to develop atrial fibrillation upon electrostimulation. So going back to calcitonin itself, because so far we've been talking about calcitonin receptor, there was a number of clinical observational studies in pediatric journals which caught our attention, which showed that thyroid agenesis, a condition when kids are born without thyroid, is associated with the same amount of calcitonin as in normal kids who are born with thyroid. So these kids actually who don't have thyroid, they have calcitonin, exactly the same as in control kids. And they have the same amount of calcium in the blood, suggesting that perhaps calcitonin is generated elsewhere and not just by the thyroid gland. Otherwise, we cannot explain how calcitonin is maintained in human body in patients without thyroid. So we went on to test the idea that maybe atria, human atria may generate calcitonin because human atria are known, or human heart and is known to generate a number of hormones such as endothelin-1 or atrial nitric uretic peptide and others. So, and what we found that atrial cardiomyocytes obtained from humans, in fact, generated a lot of calcitonin as shown here in this bar graph. And what was even more striking, that this amount of calcitonin generated by the atrial cardiomyocytes was 16-fold higher than generated by the thyroid cancer cells. And with T cells, thyroid cancer cells, they generate a huge amount of calcitonin under normal conditions, suggesting that the heart is actually maybe a major extrathyroid source of calcitonin in human body. So obviously we wanted to check whether patients with atrial fibrillation have any abnormalities of calcitonin and not just of the receptor. And we found that patients with atrial fibrillation have 6-fold lower amount of calcitonin secretion, as shown here on this bar graph. And we wanted to test whether knocking out or overexpressing calcitonin can help or can be detrimental for spontaneous atrial fibrillation. And for this reason, we generated a number of mouse models. And so what we did in one mouse model, we knocked down calcitonin in human atrial cardiomyocytes, shown here minus CT. In the other mouse model, we overexpressed calcitonin in mouse atrial cardiomyocytes. And all these mice were bred on the background of a famous model of spontaneous atrial fibrillation called LKB1 knockout mouse, or liver kinase B1 model. And so what we found that when we removed calcitonin from cardiomyocytes from this atria of mice, this atria had a lot more fibrosis as shown here and also quantified in the red bar. But when we did the reverse experiment, when we put calcitonin back to the atrial cardiomyocytes, we've noticed that everything went back to normal. Fibrosis went back to normal, like in control mice. And as we could see here also on the staining. How about atrial fibrillation? Okay, we were able to manipulate atrial fibrosis, but is it the same for atrial fibrillation? So strikingly, at the age of 12 weeks old, mice who were lacking calcitonin in the atria, they were 65% of mice were in spontaneous atrial fibrillation compared to 23% in controls. And interestingly, when we put calcitonin back to the atria, when we overexpress calcitonin in atrial cardiomyocytes, none of the mice developed spontaneous atrial fibrillation, suggesting that not just calcitonin receptor, but also the hormone calcitonin itself is important for atrial fibrillation pathogenesis and for atrial fibrosis. And fibrosis is ultimately a pathogenic mechanism leading to these abnormalities in AF. So to conclude, we identified a new and significant extrathyroid source of hormone calcitonin in the human body. But what is more important, we found that cardiac calcitonin secreted by our atria controls fibroblasts in the atria, and they ability to produce fibrosis. Therefore, this mechanism helps to maintain healthy, normal sinus rhythm. Whereas in atrial fibrillation, our atria produce 6-fold less calcitonin, and therefore the brake on fibroblasts is taken off. Fibroblasts become more active and aggressive, and they generate more fibrotic tissue, which ultimately leads to atrial fibrillation and maintenance of this arrhythmia. So we propose that maintaining physiological levels of calcitonin may be beneficial and may be a therapeutic option for patients with atrial fibrillation. And the rest of the endocrine pathologies relevant to AF are in this review that I mentioned before. And finally, I would like to acknowledge my long-term mentor, Professor Stanley Natel from Canada, who I've been working for a while, and my group, and also all these people without whom we wouldn't be able to carry out this study, and our funders, British Heart Foundation and Oxford University. And I would like to thank you for your attention.
Svetlana, thank you very much indeed. A beautiful presentation, a very exciting potential new therapeutic target. We've got time for a few minutes questions before we move on. Perhaps I could just start. The obvious initial question is, it's exciting as a target. However, as you said, calcitonin has systemic effects. What ways might there be to try to target upregulating the local heart pathway without causing unwanted effects elsewhere?
Yeah, so calcitonin is a wonderful target, and actually there is a drug already, a cheap drug, which we could buy and give patients. However, as you say, Donald, so the problem is patients develop tolerance to calcitonin, and even if it works for a few weeks, it will stop working after 4 to 6 weeks. So we need to come up with a new treatment. And that's what we are doing now. We are developing new small molecules, and currently testing them in vitro in our lab. And so hopefully the next step will be to take these molecules to the animal study and test them in animals. And if the effects are positive, then we could go to a clinical trial. We're kind of a little bit far from clinical trial, but we are working on it tirelessly, and hopefully we'll come up with a new medicine.
Can we turn now? Thank you very much, Svetlana. A question from Albert Ferro, member of our panel.
Hi, Svetlana. Yes, very nice talk from you, and from John as well. I had a particular question for you, actually, and I was just wondering whether there might be a situation where you're getting a positive feedback loop in AF, so that you get fibrosis causing loss of calcitonin producing cells that then causes further fibrosis and then further loss of these cells. Is that, do you think that's happening at all?
I think it is all possible because we still do not know the exact causes of why calcitonin is reduced and secretion of calcitonin is reduced in patients with atrial fibrillation. They're trying to look into a few potential mechanisms. So far, we haven't got a proof that fibrosis is causal, because normally fibrosis is a consequence of a long-standing atrial fibrillation, if we are just talking about AF itself, or it's a consequence of an underlying condition. However, what we know is that not every underlying condition has an altered calcitonin level. Yet, I would say that it is possible because calcitonin has been shown by many clinical studies goes down with age. So as we age, we naturally lose the ability to produce calcitonin. And if we measure calcitonin in a young 20-year-old individual and in a 70-year-old, we will see a drop by 70% in secretion of calcitonin. So I guess fibrosis may be somewhere underlying, but it's not causal probably. But certainly calcitonin, a reduction in calcitonin is causal for fibrosis in these conditions.
Thank you both. I think a final question now from Siong, which is on a similar vein. That's the same, that there are many different subtypes, and I'll hand you over to Siong to ask this question.
Fascinating talk, Svetlana. I wondered about the sort of time course of the reduction in calcitonin secretion. You say it's a 6-fold reduction, but how quickly does it happen with AF? Is it different in paroxysmal versus persistent patients? Do we see this reduction in secretion within a few days of having AF, or do you have to have it for years before you start noticing a reduction in calcitonin secretion?
A very good question, very relevant to the patients. So this study was carried out only on patients with persistent AF, obviously, but we of course looked at different time points, and it's unpublished, but we will be publishing it quite soon. So I can say that we do detect a drop in calcitonin secretion prior development of short lasting episodes of AF. So I suspect it's causal. So something happens some prior event causes a drop in calcitonin, probably age or maybe accelerated aging process that lead to prompt atrial fibrillation occurrence, because we see a reduction in calcitonin in patients who develop postoperative AF prior operation, prior surgery, which means there is predisposing factor already.
Thank you very much indeed, Svetlana. What we shall do next is to hear from Dr. Fu Siong Ing, who is a clinical senior lecturer in cardiac electrophysiology at Imperial College in London.
Thanks, Donald. Thanks for the introduction. So I'm Fu Siong Ing. I'm a senior lecturer at Imperial. So I am a clinical cardiologist and electrophysiologist, and I treat many AF patients, but I also do some research as part of my job into finding new treatments for atrial fibrillation. And what I want to do today is to try and give you an idea of where we're at with our current treatments for AF, the limitations, and where we might be headed from the mapping and clinical end of treatment for AF. So we've already heard that atrial fibrillation is a big problem, and its prevalence is increasing, and it's really increases in the 7th or 8th decade of life. So in the UK, we'd expect potentially up to 1.5 million patients with atrial fibrillation by the middle of this century. So it is a big problem. And it's a big problem to which we don't currently have any good solution. What do we know about atrial fibrillation? How are we treating it at the moment? One of the things we do know is that the pulmonary veins, which return blood into the atria, are very important in triggering atrial fibrillation. So if you look at the histological slides of the pulmonary veins, you can see a thin layer of myocardium that extends from the atria into the pulmonary veins. And it has been shown in multiple studies that this pulmonary vein sleeve harbors the trigger for atrial fibrillation. And when I say trigger, I mean the very first beat of AF starts from the sleeve of the pulmonary vein. Here's a seminal study that maps the triggers of multiple patients with AF. And you can see that many of these dots locate to the 4 pulmonary veins that plumb into our left atrium. So what do we do about that? Currently, the mainstay of treatment for our patients with AF is something called catheter ablation. And this is a procedure where we introduce catheters up to the heart through veins into the groin. And we do something called pulmonary vein isolation. I've already told you that the pulmonary veins harbor many of the triggers for atrial fibrillation. So what we do is to electrically isolate the pulmonary veins from the rest of the atria. So in this case, we perform single lesion point by point around the pairs of pulmonary veins so that the veins are electrically disconnected from the atria. So in this example, you can see by doing so, the pulmonary veins continue to fibrillate. Electrical signals are fibrillating here. But in the left atrium, they're in sinus rhythm. So the veins where the triggers are can fibrillate, or we keep the patient in sinus rhythm because the atria are disconnected from the veins. Here's another example where we put a balloon up to the veins. Here's the pulmonary vein that pacified with some contrast. We inflate a balloon and we essentially freeze around the vein to again electrically isolate the veins from the main atria to stop the triggers from propagating to the atria. Now, this works relatively well for paroxysmal AF, and we heard from Svetlana, the problem really is in persistent atrial fibrillation. With a single procedure, you can see in this Kaplan-Meier survival curves, it is a pretty bad result. About 30% are free from AF after 1 procedure. And even with 2 procedures, you'll be lucky, it's a 1 in 2 chance that we can keep you out of atrial fibrillation in about 5 years. So despite our best efforts, this procedure is insufficient. And part of the problem that we heard from Svetlana is this issue with remodeling. Here on the vertical axis, we have our vulnerability to AF. And here is time. We obviously have a genetic predisposition. And as we age with multiple factors, we get more and more vulnerable to atrial fibrillation. And every time with AF, we accumulate more remodeling. So that by the time we get to this stage in persistent AF, treating the triggers alone is insufficient. And that's why we need new treatments, like what we've heard in the previous talk, to try and treat persistent atrial fibrillation. From the clinical perspective, we've tried various techniques, really with very limited success. Our community went through this phase where we retrospectively termed learning by burning, where in addition to targeting the pulmonary veins, we try to ablate around the atrium to modify the substrate, either by drawing lines in the atrium, targeting specific signals, burning the nerves, or mapping the drivers. None of these adjunctive treatments have really helped us improve the outcomes for our patients. Here in this example, comparing just pulmonary vein isolation, the standard ablation, with a couple of additional adjunctive treatments, we can see we're no better doing more ablation to our patients. We're still stuck at this 50% ceiling of success. To the extent that recently NHS England have said we should probably limit offering AF ablation to patients with persistent AF because we're not very good at doing it and we've got very limited success rates in helping our patients. So examples here, if you have it for more than 2 years, potentially you may no longer get an ablation for atrial fibrillation. So what is the problem? Well, I think the problem is because we're not clever enough from the clinical end to distinguish different types of atrial fibrillation. Over the last 100 years, there have been many debates about how AF is sustained in the atria, i.e. how the electrical waves propagate around the atrium. There are some who think there is a single spot that is driving atrial fibrillation, a rotor. And the others who think this is a really disorganized rhythm where it's chaos, there's no pattern to the propagation. But we don't take this into account when we treat our patients. We treat AF as one single entity and we don't direct our treatments towards the different subtypes. And a lot of my work has been trying to disentangle the different subtypes of atrial fibrillation and how different degrees of remodeling lead to different forms of AF, which may require different treatments. You don't have to be an expert in looking at electrical signals to say qualitatively that this signal here looks far more organized than this signal here, which looks very fine and disorganized. Yet currently we treat all of this as fibrillation and we treat them all the same way and treat them all the same way with the same drugs and with the same ablation. And what I feel is we need to move away from that to think about fibrillation more cleverly and to classify them into more fine subtypes. Here's an example of some experiments that we did. We modified gap junction coupling, which is important in allowing for propagation of the electrical wave through the heart muscle. And if you can see, using high resolution mapping, so we're looking at micrometer level, how the electrical wave propagates through the heart, we can see different patterns of fibrillation. On the right, with very well coupled myocardium, you get a very organized form of fibrillation, almost like a tornado or something rotating around the heart that sustains the fibrillation. On the other hand, if you were to uncouple gap junctions, you see this very messy, very different form of fibrillation that looks very disorganized, very messy, very chaotic. Yeah, these are all atrial fibrillation. These are the sort of spectrum of diseases that exist in our patients, and we have to tailor our treatments to the specific subtype. We talked about fibrosis earlier, and we are also very interested in fibrosis. We looked at not so much whether they exist, but the different patterns of fibrosis. My view is not all fibrosis is equal. We looked at different macroscopic forms, so very diffuse interstitial fibrosis and patchy fibrosis, and again, mapped the type of fibrillation. And we found that, like with gap junction coupling, you saw a spectrum. They're not all the same. You've got fibrillation that's very organized on this end that is driven by rotational drivers. You've got fibrillation on this other end with different forms of fibrosis that is very disorganized, that looks a bit more messy than this on this end. And we postulate this concept of different electro-phenotypes of AF and how we must take this into account when we treat our patients. AF is not one entity, and there's a range from very organized to very disorganized atrial fibrillation. And where you're at on this spectrum depends on the degree of remodeling in your atria. And on this end, this is the most easy to treat, and on this end, probably the most difficult to treat. So what's our problem? Why don't we just use that to guide our treatments? One issue is that the electrical signals we record from the heart look a bit like this, and we record it with very limited spatial resolution using a basket like this. And we really have no hope of trying to tell what's going on in your atrium just with some very limited electrical recordings from a basket like this. Some of our work has been really much focusing on signal processing. So we borrowed from the world of economics. So Clive Granger won the Nobel Prize about 20 years ago for this method called Granger causality, where they looked at different time series like inflation, exchange rates, and see whether one is causing the other. We've adapted that for fibrillation, and we're using this technique now to look at whether different signals from different locations of the heart are causative of one another to work out the propagation patterns and the type of fibrillation. And in this example, we can see we're able to use low resolution data and work out the propagation patterns of fibrillation around the heart. So how the electrical wave is moving around the heart muscle to guide us in deciding what ablation to do, what treatments to administer, and also what drugs that patients might respond to. So just to finish, this is where I envisage how we might end up treating atrial fibrillation if we don't find a sort of wonder drug to treat all the patients. I think we must start to distinguish patients from different subtypes of atrial fibrillation. We must be able to be more clever in mapping what type of propagation pattern they have, using a combination of the ECG and imaging like MRI to look at the scar patterns, and then prescribe the right form of treatment for the right form of atrial fibrillation. After all, our cancer colleagues treat different cancers differently based on the molecular base of the cancer. We in cardiology need to be a bit cleverer. We must think about how we prescribe treatments based on the phenotype of atrial fibrillation. So I want to finish by thanking the research group. Most of this work was done by Balvinder Handa and Young Lee. And I also want to finish by thanking specifically Donald Singer. About 21 years ago, I was an intercalated BSc student in his laboratory back at St. George's. And it was during that 1 year that I was particularly enthused about clinical academia. And I'm only doing what I'm doing now, partly because of the inspiration from Donald's laboratory. And this is the final slide. This is what we're trying to do. Fibrillation often looks like this when we map it. What we're trying to do is look for the order within the chaos to find patterns to treat our patients. Thank you very much.
Well, Siong, thank you very much indeed. Again, very, very clear and beautifully illustrated. And I like your very last image there too. What we're going to do now is take questions together at the end. If we can move on now, just to think about other aspects of clinical management, what's possible at the moment. We heard from Svetlana that one of the big concerns about atrial fibrillation is the very high risk of stroke, preventable stroke. I shall turn now to Albert Ferro, Professor of Cardiovascular Pharmacology at King's College London, to discuss what we should be doing to protect our patients with atrial fibrillation from stroke.
But anyway, I just want to thank Donald again for inviting me to be on this panel. We've heard some great research that's going on at the moment in AF, and I'm going to talk a little bit, as you heard, about what we do about the risk of thromboembolism in stroke in practical terms. And you've heard from various speakers that this is a major issue with atrial fibrillation. You heard from Svetlana that AF is the cause of something like 25 to 40% of all strokes. Having atrial fibrillation increases your risk of stroke by between 5 and 7-fold. So a major plank of treatment of these patients, never mind what you do about the rhythm and so on and the rate, is preventing thromboembolic complications, stroke in particular. So that really comes down to the use of anticoagulation therapy. And I'm going to focus on that really. And there are two scores that are used commonly when deciding around anticoagulation. One is the so-called Chadsvask score, which gives an indication of thromboembolic risk. And the other, which I'll come to in a minute, is the Hasbled score, which is more an indication of bleeding risk on anticoagulants. And obviously, if you put somebody on an anticoagulant, you'll help to prevent thrombosis. But of course, you have to balance that against the risk of bleeding. So this is the Chadsvask score, which stands for various letters in the name. And the twos there mean that they're scored rather higher than the other components. So C stands for the presence of congestive heart failure, H is hypertension, and it doesn't matter whether you're on antihypertensive therapy, if your blood pressure is well controlled and so on, you're still at higher risk of thrombosis. So you'll get a point awarded for each of those, a point being a bad thing in this case, not a good thing. If you're 75 years old or older, you actually get 2 points because you're at particularly high risk of thrombosis there. That's the 2 in the A bit. Diabetes, doesn't matter if it's type 1 or type 2, gives you a point. And previous history of stroke, TIA, or thromboembolism will give you 2 points on that. It was originally the CHADS2 score, and more recently, the VASC bit has been added in. V stands for the presence of vascular disease. A is age again. So you heard that being 75 years old or older is a particularly high risk, but it's also a bit of a risk if you're between 65 and 74. So you get 1 point for that. And then you've got sex, because being female gives you 1 point as well. And it's important to stress here that actually sex here is not a risk factor as such. It is more a risk modifier for stroke. What do I mean by that? Men and women who have no other risk factors are at about the same risk of thromboembolism. There's no difference between men and women. However, if you're female and you have other risk factors present, then you are going to have a significantly higher risk of thromboembolism. So you add up all the points and you get a score for that. That's the Chadsvask score. Then you got the Has-Bled score, which gives you an indication of risk of bleeding on anticoagulation. So H stands again for uncontrolled hypertension. A is abnormal kidney or liver function. You can see that a lot of these exist in both the Chadsvask and the Has-Bled. So there are risk factors both for thrombosis and for bleeding as well. So stroke appears here again. A prior history of bleeding or predisposition to bleeding. An INR if you're on a vitamin K antagonist such as warfarin. If you've got a very labile INR so that your time in the therapeutic range is low, it's less than 60%, then again, you're going to be at high risk of bleeding. Being elderly and being on drugs like antiplatelet drugs or non-steroidals, which inhibit platelet function, or drinking excess alcohol, all of those will give you an increased risk of bleeding. Should a high Has-Bled score stop you from prescribing anticoagulants? And the answer is no. And a lot of people get quite worried about this. But essentially, if you have a high Chadsvask score, then you should be anticoagulating. The Has-Bled bit of it means simply that you should be monitoring them more closely for possible complications, for possible bleeding. So you shouldn't necessarily let Has-Bled dissuade you from using anticoagulants. You should use it more for dictating that you should be following up these patients much more closely. So here's a flow chart. If you've got a patient with AF who's got a mechanical heart valve or mitral valve disease, you just go straight to a vitamin K antagonist, warfarin or whatever. In other patients with AF, you then have to identify who's at low risk and who's at high risk. And that's what you do with Chadsvask. And essentially, if Chadsvask is 0 for a man, 1 for a woman, then you don't need to anticoagulate. If it's 1 for a man or 2 for a female, you should definitely consider oral anticoagulation. If Chadsvask is 2 or more for a man and 3 or more for a woman, then you definitely should be going for oral anticoagulation. By and large, these days, we tend to use the NOACs or DOACs, as they're more commonly called now, the direct acting oral anticoagulants. And we tend to use them in preference to the vitamin K antagonist. There might be some reasons why sometimes you veer away from the DOACs and go for a vitamin K antagonist. For example, patients with severe chronic kidney disease, patients with particularly low body weight, and so on. And if you are going to think about a vitamin K antagonist, you can use this thing called the same TT2R2 score to determine how likely it is that they'll be able to control the INR within the therapeutic range well. If they have a low score on this, then it's likely that the vitamin K antagonist will be well controlled as far as the INR is concerned. If it's high, then really that's telling you they're going to be quite difficult to control, and you should more veer towards a DOAC. So in patients who are on vitamin K antagonists, whose time in the therapeutic range is low, that's to say less than 70%, then you should really think about switching to a DOAC. Or if you're going to stick with a vitamin K antagonist, try your best to improve the time that they're within the therapeutic range with education, counselling, more frequent checks on their blood. Importantly, in the old days, people often used to prescribe antiplatelet drugs like aspirin or clopidogrel for atrial fibrillation. That is not recommended anymore. They are not effective and they should not be used in that situation. They've got other indications, but not for atrial fibrillation. You should use the estimated bleeding risk, and that should not in itself guide treatment decisions to use oral anticoagulants, but more as a guide to how frequently you should follow them up. And importantly, also, it doesn't matter what the pattern of the AF is, whether it's first detected, it's paroxysmal, long-standing, permanent, whatever, all of those are equal candidates for thromboprophylaxis. And just finally to say that if you have a patient who is a particularly high risk of bleeding with long-term anticoagulant therapy, there are other options that can be considered, including left atrial appendage occlusion, which can be done through a catheter, or in a patient who's undergoing open heart surgery for other reasons, they can have surgical occlusion or exclusion of the left atrial appendage. And those procedures will allow you to get them off oral anticoagulants if their bleeding risk is particularly high. So,
thank you very much indeed, Albert. A very clear discussion of what we should be doing. For our final talk before the panel discussion, we shall hear now from Professor Bernard Cheung, who is a Professor of Cardiovascular Pharmacology at the University of Hong Kong, as well as a trustee of the Healthy Heart Charity and editor of the Postgraduate Medical Journal. Bernard will give us some practical advice on what to do about rate control in patients with atrial fibrillation.
Donald, well, now we heard earlier on that using catheter ablation to return the patient into sinus rhythm, that's a laudable thing to do. But we also heard that it's not always possible to do that. It's good. It's a good thing to achieve if you can get the patient back into sinus rhythm, because the cardiac output is better on the whole when the patient is in sinus rhythm. However, maintaining the patient in sinus rhythm over months and years is difficult. And also, if the patient stands a chance of lapsing back into AF, paroxysmal AF, you can also get the kind of thromboembolic strokes that Professor Ferro mentioned just now. And so these patients would really require anticoagulation to prevent these embolic strokes. And another thing is that we haven't touched on too much about using drugs for rhythm control, is because the results are quite poor, and certainly much inferior to the results of catheter ablation. So basically, in all patients with AF, rate control has to be considered. Although actually not all patients require rate control. If they are, let's say, if the rate is not too high and they are relatively asymptomatic, then perhaps you don't need to give the patient a drug to control their heart rate. And in considering the heart rate, don't just look at the exercise heart rate. In other words, the maximum heart rate. You should also look at the resting heart rate as well, because the drug may, in controlling the maximum heart rate, you may also find that the resting heart rate is too low, and vice versa. The choice of drugs depends on a number of patient factors, including concomitant diseases. So in this next chart, it shows probably the 4 most widely used drugs prescribed to control the ventricular rate in people with atrial fibrillation. And I think all of them are reasonably familiar. You have the beta blockers, for instance, metoprolol and atenolol. They are particularly useful for patients with ischemic heart disease and those who have heart failure with reduced ejection fraction. Beta blockers also lowers blood pressure, so they're quite useful for patients who are hypertensive at the same time. But of course, you have to be cautious if the patient has asthma. Calcium channel blockers, particularly of the diltiazem and verapamil type, rather than the nifedipine or lodipine variety. These calcium channel blockers reduce blood pressure and contractility. So Again, if the patient has a greatly reduced ejection fraction, then perhaps, these are not the best choice to control their heart rate. Digoxin, on the other hand, is not negatively inotropic. It will not reduce contractility. However, it's kind of gone out of fashion these days. And also, another consideration is it's excreted by the kidneys. And so if the patient has poor renal function, then you would have to reduce the dose or do drug levels and monitor these drug levels carefully. Lastly, we have amiodarone, a fairly old drug with a very long half-life of something like a week. The newer drug in this class would be dronedarone. However, chronic use of amiodarone leads to multiple side effects in different organs. So I think one has to be careful about the cumulative dose of amiodarone. Although in the short run, it is very good. I mean, it actually doesn't just achieve rate control. You can also get rhythm control. It will actually convert the patient back into sinus rhythm. Dronedarone is the newer drug, but it's actually less efficacious. And there have been trials that showed that patients on dronedarone actually had worse outcome. So dronedarone currently, if you look at the sort of labeling, package insert, it actually says it's contraindicated in permanent AF and in patients with severe heart failure. This is the last slide. So what are the aims of rate control? Well, you aim to get the appropriate heart rate for the patient, which can be different in different patients. In general, in recent years, we tend to be quite lenient with the rate control, i.e., as long as the heart rate is less than 110 beats per minute, we're quite lenient about that, provided the patient is asymptomatic. There's no merit in trying to suppress the heart rate to, 72 beats per minute. I mean, partly because for certain patients, they might actually need a slightly higher heart rate, to achieve the cardiac output required. Okay, so it's a balancing act. On one hand, you don't want the heart rate to be too low, because if you try to suppress the heart rate too much, you'll be using quite high doses of drugs, and then you get the drug adverse effects. If the resting heart rate is too low, you have bradycardia, perhaps even syncope. You may even need a pacemaker if the heart rate becomes too low at times and the patient has syncope. On the other hand, you don't want to leave the heart rate too high because the symptoms of atrial fibrillation, such as palpitation, shortness of breath, will occur. And also, if the heart rate is too high, the quality of life is impaired. And a high ventricular rate is also associated with heart failure and stroke. Okay, so that's the end of my talk. Thank you for your attention.
Thank you very much indeed, Bernard. Thanks to you and also to all our panel for highlighting some new possibilities, but also thinking about the best clinical current practice. What we'll do now is have a brief Q&A session. And for our audience, do please use the chat button if the questions you'd like to address. Can we start with you, Siong? There's a question via John Jackson. What about the role of pacemakers in arresting the progression, which was well described by Svetlana and also by Bernard?
Yeah, it's a great question. Often, lots of people ask me that question: can I have a pacemaker to stop my AF? The answer is not directly. So pacemakers have a role in trying to help us manage atrial fibrillation. A lot of the time when you have paroxysmal AF, the symptoms you get don't just relate to your heart rhythm being irregular, but it's more because it's fast. It's fast and irregular, and that's why you feel it. And we heard from Professor Cheung that one of the ways is to try and control the heart rate, but we sometimes end up in this situation where we're a bit stuck because we gave you too much beta blockers and you go too slow when you're in a normal rhythm. And then when you're fast, you're too fast. And one way to do that is to use a pacemaker, help us get the right balance. So you can have a pacemaker to make sure the heart rate is never below 60. And therefore you can be very liberal in then throwing in all the medication. So you will sort of attack from both sides. And you're happy that you'll never get too slow because the pacemaker is there as a backup. And as a last resort, we sometimes do something called AV node ablation. So we put a pacemaker in and we burn not the veins, but the middle of the heart, the AV node, to stop the atrial fibrillation from getting to the ventricle. So the heart rate slows down and is regulated by the pacemaker. So the answer, I guess, is partly yes. It helps us manage it, but not directly stopping the progression. I hope that helps, John.
At the moment is we have current treatments which may be flawed, and you have to think about the underlying causes and passions. But how well are we doing in terms of preventing these complications, preventing, for example, stroke in particular? We've got these scores that you mentioned, Albert, but what about success in the UK, success in other countries in making sure patients and health professionals are aware of what they should be doing?
I think we're doing better than we were a few years ago. I think there's still a way to go. I think the fact that we now have the newer type anticoagulants, the DOACs, which don't need monitoring, has been a major step forward, and given people confidence to use these drugs, anticoagulants more widely. And warfarin has always been a bit of a pain because you need periodic blood tests. It can be very difficult to control the right degree of anticoagulation and so on. So certainly, I think the arrival of the DOACs has been a major plus. And I think has improved our success in preventing stroke thromboembolic complications. I think there are still quite a few doctors out there who use things like aspirin prophylactically in patients with AF. I think we've still got a bit of a way to go to get the message out there that we really should be anticoagulating these patients with a very low threshold. So we're doing better than we were, I think, but I think there's still a bit of a way to go.
What about other countries, Bernard? What's it like in Hong Kong in terms of the message out amongst health professionals getting these medicines used well to prevent stroke, and those safe to do so?
Well, yes, I think there's a lot of awareness of the need for anticoagulation. And then, of course, in recent years, the DOACs are available. But cost is because in Hong Kong, many of these eligible patients will have to pay for the drugs themselves. Those with the highest Chadsvask score will get the free drug from the health service. However, in a year's time, or perhaps in 2 years' time, there'll be generics of DOACs. I think that would really, make these drugs much more readily available in places where it's not free.
Thank you, Bernard. A question I think both for Svetlana and possibly for Siong. What about biomarkers of risk of fibrosis? There's a question from Penny about what about using calcitonin levels to predict risk? And perhaps you can say, what about other markers, the biomarkers of fibrotic risk, and how that might help clinical practice? Svetlana first.
Thank you very much. Yeah, it's a very good question. Very difficult one, because there is no specific biomarker of fibrosis apart from measuring it in the heart using high resolution, maybe CT scan or MRI, magnetic resonance. But otherwise, we struggle to find the biomarkers of fibrosis because fibrotic tissue presents in every organ. And even if we try to take a blood test, we would know where this biomarker is coming from the heart or from the liver or from spleen or elsewhere. In terms of calcitonin to be one of them, I doubt it would be, because calcitonin is secreted by, as we know, by the thyroid gland, and it may have nothing to do with fibrosis. So we are currently working on new biomarkers. In fact, my group is running a study, clinical study, trying to look for novel biomarkers in atrial fibrillation, not just in fibrosis. In a cohort of patients undergoing cardiac ablation and cardioversion, because obviously patients who undergo cardioversions are doing much better. So we are trying to rule out or to see the differences in release of biomarkers in the circulation, in the bloodstream, and whether we could identify, well, a simple, but obviously it's not as simple as it sounds, marker in the blood test that would tell us which patient will do better, which patients will do worse upon ablation or cardioversion. But the answer is no, there is no biomarker of fibrosis.
And Siong, just maybe to pick up on something you were talking about, what about the practicalities and clinical practice of high resolution imaging? Given the scale of the problem, how many patients out there have the condition, is it feasible to use that?
Yeah, I mean, it's clearly very, very difficult and not widely available. Or moving towards trying to phenotype atrial fibrillation using the ECG, using machine learning. If we have, say, 50,000 ECGs and we know what type of AF they have, we can probably use a combination of ECG, which is available, and perhaps cardiac MRI, which is a little bit less available, but still available, to try and categorize patients based on their mechanisms.
Thank you, Siong. Maybe a further question for you, or perhaps for Bernard. What about the question from Chris Ellis, using flecainide or not? Why not to use it as an antiarrhythmic drug treatment?
You can do a chemical cardioversion using flecainide, although I'm not sure about the long-term outcome data. So on to you.
Yeah, I mean, I like flecainide for my otherwise healthy, structurally normal heart patients who are early in the process of having AF. Lots of studies in the 90s, the CAR study showing that flecainide can be pro-arrhythmic if you have heart failure or coronary artery disease. But it's a very good drug if you're otherwise healthy with normal heart and no coronary artery disease. And lots of patients are maintaining sinus rhythm with flecainide for many, many years if they can take it. It's just a small minority can have trouble with it, and you actually end up getting ventricular arrhythmias, which are dangerous from the flecainide. So within the right patient, it works well.
Oh, can I add something about SGLT2 inhibitors? These anti-diabetic drugs seem to be a cure of everything, and there's some data showing that SGLT2 inhibitors will reduce the risk of developing atrial fibrillation, and it also seems to work via reducing fibrosis. So, I mean, it's not an indication yet, but I think watch this space. I think there are more data.
Can I just add to that? Sorry. We reviewed these drugs in this review in Cardiovascular Research article, which I was showing in my talk. So please do look at it. So actually, it does look promising, and it's one of the hormonal therapeutics coming to light. So yeah, watch that space.
A question now from Vinod on chemical cardioversion. Is it dangerous perioperatively?
As long as you're anticoagulated. So one of the risks of chemical cardioversion is if you're not, when I say perioperative, I wonder whether you mean another operation. Clearly, in the context of AF ablation, we cardiovert them a lot during the procedure. It's not dangerous because you're monitored, and as long as you're anticoagulated, you negate the stroke risks.
Thanks, Fusil. Do you have a question, Albert?
Yes. So coming back to antifibrotic drugs, Svetlana, I have to read your review, so it'll probably all be in there. But the other thing I was thinking about was aldosterone antagonists like spironolactone, which have been widely touted in hypertension circles as having some antifibrotic properties as well. And I just wondered if there was any evidence for their usefulness in this situation in AF.
They are useful in particular situations, but not in the majority of patients. And as we write in our review that when patients have an underlying condition associated with altered RAS system, renin-angiotensin systems, then yes, they would be definitely, or aldosterone, they would be useful. However, we cannot prescribe this drug to everybody because not everyone has abnormalities in this pathway, and we don't necessarily want to alter it because obviously aldosterone is a vital hormone for maintaining a lot of functions. Therefore, different therapeutics, like including hormonals, they can be useful in a particular cohort of patients. So we have to know the patient so well, and perhaps we should measure the hormones before we go for spironolactone or something like that. And that's what we are trying to introduce. One of the concluding remarks that perhaps we should measure thyroid hormones in these patients. Perhaps we should improve screening of this before we think about anything else. We just underdiagnose them. And because they're under investigated, under examined, so we don't know a lot about them. They're all kind of in a bulk, but actually we need to separate them in order to be to tailor the treatment to a particular patient.
Thank you very much, Svetlana. A question for you, John, as patient. We've heard about very expensive, sophisticated approaches, but what do you do in practice in terms of self-monitoring to keep an eye on your heart rate? And
thanks, Donald. You mentioned previously that I'm a Fitbit wearer, and I have been for a number of years. And I have to say, despite the fact my specialist frequently tells me to ignore it because it can be inaccurate as much as 20 to 30% up the way or down the way, it is a brilliant way of just keeping a general monitor on how your heart is functioning. Some of the comments that were made earlier about the challenge of resting heart rate, I found particularly interesting because my resting heart rate tends to be all over the place. Can be up as high as 75, nudging 80. I get a bit anxious when it starts to drop below 50. So Fitbit is absolutely brilliant. And I guess the other thing is I went through my cardio rehab program and was given all sorts of good advice on good regular exercise. So I kind of have a 30 to 40 minute walk after breakfast pretty much 6 to 7 days a week nowadays, and that tells me how well I'm set up for the day.
Of each other, Bernard.
Yes. Well, question to John. Do you have to give up alcohol?
Oh, Bernard. I decided I would give up alcohol for Lent, which you know is 6 weeks of abstinence. And as somebody who really enjoys a good glass of red wine, that was a hell of a challenge. But I was conscious that even if I had just one glass and a top up on a couple of evenings in succession, Friday night, Saturday night, and Sunday lunchtime, it had significant consequences for my heart rhythm for the next week or so. So I did it as much as for that as for feeling particularly noble. And of course, soon after giving it up, I ended up in the A&E department of St. Mary's Hospital here in London. And the triage nurse, when I told her about this, said, well, you see what happens when you give up alcohol. But yes, it does seem to have an effect, Bernard. And I'm particularly sorry that I can't enjoy my wine the way I used to.
So you're drinking in moderation now?
In moderation, absolutely.
Right.
Any final comments or thoughts from the panel? Albert?
No, I think it's been a really interesting discussion.
Svetlana?
Yeah, I enjoyed it. I learned a lot. Thank you very much for inviting me. And
John?
Yes, as a patient, I found all the presentations incredibly informative. So thank you all.
Bernard?
Well, I enjoyed it.
Siong?
Enjoyed it thoroughly. Great session.
I'd like to close by thanking all our panel from the UK and from Hong Kong for a wonderful session, and you from around the world for joining us. You can find out more about Healthy Heart webinars by going to our website healthyheartcharity.org.